Good evening, everybody. Thank you for joining us for episode 7 of the Aging and Elderly series. As you come in, please mute yourself if you're not muted already. It's a pleasure to have all of us here. If you have friends that need to be part of this, please invite them to join the Zoom or to join us on YouTube. Zoom would be preferable so that they can ask questions when it's time for the Q&A. And I'm happy to let you know that our speaker is already in the house and we'll be starting very, very shortly. Temitope Ayedun, also known as the Praising Child, and you're all very welcome. Okay, so there on our screen is our guest speaker for today. I'll just be introducing him very shortly. Dr. Olusegun Shoyombo studied medicine and surgery at the College of Medicine, University of Lagos between 1998 and 2005. He holds a fellowship of the National Postgraduate College of Nigeria, Faculty of Psychiatry, and a master's degree in gerontology from the University of Southampton in the United Kingdom. Dr. Shoyombo works as a senior consultant psychiatrist at the National Hospital Abuja, the nation's flagship hospital. He's very keen about physical exercise and believes in the saying that what is good for your heart is good for your brain. In his spare time, he enjoys reading and playing squash. He is married to Victoria and they are blessed with 2 children. Join me as we welcome Dr. Shoyombo. The floor is yours, sir. Thank you for joining us.
Good evening, and thank you. Good evening, everyone. I'm happy to be here. In the next hour thereabout, we'll be discussing mental health and aging. I hope that we will have a very good discussion, and then we'll take questions afterwards. So I think I'll get straight into it. I've been introduced. The theme is mental health and aging, promoting mental well-being in older adults. Okay, this will be the outline for the presentation. We are starting at about 7 minutes past 5, so we keep track. What is aging? Who is an older person? What is the situation in the Nigerian context? I know that I'm talking to people from across the world. You will forgive me. I'll describe the elephant from the side of the room that I am in. What are some of the physical changes that we see in the brain as we grow older? And then what are the psychosocial changes we experience? And then we'll get into the meat of the matter. So by way of introduction, and I might want to gloss through this because I know we've been having series of lectures and some of these things will be repetitions from the things that we've heard before. Nevertheless, older people are usually physically as well as mentally frail. And you will be asking, why am I starting on this negative or doom note? You will understand as we go on. Not only are they physically and mentally frail, they usually would have some sensory deficits. What are sensory deficits? They might have impairments in their vision, hearing, feeling, taste, and things like that. Therefore, care plan must be designed to meet everything, every kind of challenge that they can have: physical challenges, social challenges, and psychological difficulties. 6% of the world's population are aged above 65. And this segment is the fastest growing segment of the world's population. And I guess you know why. Because we have conquered the diseases that used to kill us before we grow old. Hypertension, diabetes, infectious diseases, even HIV and AIDS are better managed. Even people who have sickle cell disease are better managed, and people with chronic health conditions are living far longer than they used to 100 years ago. In Nigeria, this population represents about 6.4 million, and that's a 2005 estimate. As of 2025, it had grown to about 11 million. That population is more than the entire population of many countries. Why should we be having this conversation? Well, we are all growing older by the second. I am older now than I was when I started this conversation. Some of us in this group may already be in that age group. I wouldn't know. If you are not, you are certainly approaching it. Not just that, you probably have aged relations. If your parents are still alive, uncles, aunts, grandparents, there is somebody around you who is in this population of older persons, and that is why we should pay attention. Older persons are an invaluable resource in the care of children. So they are not a burden in the society. Usually when we japa, they are the ones we fall back to. Look for visa for mommy. Let her come and take care of the children so that we can go out to work. Even when we don't japa, if we japa internally, you are in Abuja, you bring your mother from the village to come and help you. We get wisdom nuggets. It is their presence that helps our children to learn our language. They tell us history. They are the repertoire of everything that has happened in the past. I can control everything. I cannot control this, my naughty dog. So ignore the noise. So what is aging and what is not aging? Aging from the Cambridge Dictionary talks about something that relates to getting old. But from evolutionary biologists, it is an age progressive decline, mark the word, decline in intrinsic physiological function, leading to an increase in age-specific mortality rates. What does that mean? Some people die and they say what killed, and they say the person died of old age, as if old age is a disease. You know, the same way we say the person died of a stroke, a hypertension, a cardiac attack, or something like that. Say somebody died of old age. But what this definition is telling us is that from the time that we were born, we grow old and get to a certain point where functionality begins to decline until we exit. Because we don't just drop dead. We are not robots with batteries that will work in the morning and then suddenly stop working at night. Usually it's a gradual decline. The National Institute of Aging describes it as changes that occur over the course of life. That is a friendlier definition because we know that over the course of life, certain things will change. For example, I wasn't born wearing these glasses. Over the course of life, I started wearing glasses. And it depends on your age. Some of the things that you saw your mother or your father, what they did several years ago, you are probably already doing them now. You used to wonder why somebody would have an entire bag or bowl filled with medicine, or why somebody would get up from a sitting position and hold their back and let out a kind of pain sigh, oh, because they have back pain, but you are probably already having that back pain too. So these are changes that occur in the course of time. Aging is inevitable, it is irreversible, but it is not necessarily negative. It is inevitable. For as long as you remain alive, you are growing older. It is irreversible. People have done all kinds of experiments. They are still doing them. Injection of Botox, use of whatever, all supplements and things just to reverse time, but nothing has quite worked the way people envisaged it will work. But it's not all negative. Like I said, from when we were born, we started growing older. So what do we say? What is our general attitude towards aging? In this part of the world, we have a very large movie industry called Nollywood. And if you are here, I want to imagine that you know what Nollywood is. How do they depict older persons in our movies? Witches, wizards, the wicked mother-in-law, the wretched old man in a village that is suffering from past evil that he did. Just go and look at our own videos. Mother-in-law, always wicked, always terrible, always a demon. And that's the depiction we see in our movies. How about in our religious houses also? When they see a vision in places where those kind of visions are seen. I'm not sure I've seen one where they said, oh, it is your daughter that is doing you. It is your mother that is doing you. It's your mother-in-law that is doing you. If the child doesn't have children, oh, your mother-in-law has tied your womb, or your mother has tied your womb. How do grandchildren view our older persons? Irritant. That old woman who comes to insist that we cannot watch television in the morning, or we must greet in a particular way, or we must speak a certain language, is just there irritating everybody. When is grandma going? When is grandma going to her house? That is what they'll be asking their parents. And others think of them as old school, expired, a drain on resources. Why should we spend money on them? Let these people exit service, let new brains come. And that takes us to the next thing there on that slide, ageism. Ageism talks about stereotypes, prejudice, discrimination on the basis of a person's age. When we say somebody cannot do this, basically, typically, just on the basis of age, then we are guilty of ageism. So, with an older person, no general standard. Agreed cutoff usually is around 60 years of age. Developed countries use 65, they retire later. Around here, it is realistic to think of it from the age of 50 or 55. But let's just think. This is not particularly religious gathering, but I'll use the church as an example. If you looked at the Pentecostal churches, when we had the proliferation of Pentecostal churches, it seemed as if the people they were calling elder, were people in their 40s in those days, because usually there were congregations of very young people, and those who were in their 40s or maybe early 50s would seem to be the oldest people in that congregation, and they were called elders. So it depends on the demography of a place. So you go to the West, you go to England and Japan, where people live up to 120 and things like that, and typically they start counting from 65. But here, perhaps because we're a low-income country with lots of suffering, if you look at the wear and tear, if you use something, it grows. If you use something more, it grows older faster, isn't it? If you have a pair of shoes and you wear those pair of shoes repeatedly, they will get worn out easily. Therefore, the person who lives in a place where they do not have access to facilities, they trek to farm, they trek back home, they do menial and crude work, they tend to age faster than people where they have some comfort. That's why we say around here, we'll typically use 50, 55 years of age. Some other places, the cutoff is the pensionable age limit, and that's why in Nigeria, typically it's 60 years old, because that's the pensionable age limit. In some professions, that has shifted to 65, and in fact, 70 for some. So physical changes that may occur in the brain. Brain has weight reduction. You know, when you were born, when I was born, my head was not this big. And I can imagine that that is true for most of us listening this evening. However, in the course of development, the brain size grew and grew. Now it gets to a point where it stops growing because we're not producing new neurons. We now get into a stage of steady decline. And at a certain stage, it becomes clear that the brain is shrunken in size. Now, if you look at some of the prominent older persons, or if you have an older person in your family, somebody who might be, say, 80 or 90 years old or something like that, just pay some attention. You'll see that, oh, grandpa's cap that used to be so tightly fitted now appears to be loose on his head. It's because generally, not just the brain size, but even the head size has reduced, okay? So reduces and the percentages are there. Ventricles enlarged, meninges thickened. These are medical terminologies that will not bother about. But just to say that even on brain imaging, when you go and do CT scan and brain MRI, there are changes seen in the brain of older persons compared to the same brain when that individual was younger. Volume reduction is in hippocampus, frontal cortex, and cerebellum. Loss of neurons, which is basically the basis for the reduction in cell size, because the cells that make up the brain are neurons. And as they get, as we lose neurons, what it means is that we are losing brain mass. Of course, accumulation of synapse plaques and neurofibrillary tangles, these are important when we get to discuss dementia, which I will really not discuss because I know that a neurologist has spoken to us. How about psychosocial changes? As people grow older, life circumstances will change. Retirement is one of those life circumstances. That's the age at which you stop active work, especially in civil service, okay? Reduced social contact. When you were going to work, you had a lot of people above you, people beneath you, people in other organizations that you interacted with. All of these people will bring wedding invitation, burial invitation, birthday invitation. You retire one day and realize that they've all disappeared. You don't have them around you again. Pension may not be as high as salary, so income may reduce as people grow older. Of course, bereavement. Yoruba people have a proverb that you will choose one between living long and not seeing evil. You cannot have both. If you live long enough, you will see small shaggy. The longer you live, the more bereavement you will experience. Those who were alive in 2020 saw COVID. Those who died in 2018 did not see COVID. So widowhood, people lose spouses, they lose siblings, they lose colleagues at work. That happens as we grow older. The tendency to live alone after the loss of a spouse, children are older, they are living their own lives, they've traveled abroad or moved to another city. The tendency is to live alone or to live with paid help. Unfortunately, we have lost significantly the communal help that we used to have. Usually, there would have been one relation or the other that would live with us, but that culture is fast diminishing. But on the positive side, there's increased leisure time. I've seen a lot of retired people who wake up in the morning and say they are going to have a game of golf. And that is a game that takes about 4 to 5 hours to play. So it's not all negative. So when you grow older, you are not rushing anywhere. You are not going to work on Monday. You can take your time at the party. So there's plenty of time for leisure. So what are the neurobehavioral disorders? These are things that have to do with the nervous system. So it talks about brain damage or dysfunction, which produces intellectual impairment and or abnormal behavior. This will include psychiatric disorders or what we call organic brain syndromes. And I'll quickly differentiate between them. When we talk about psychiatric disorders here, we're talking about functional disorders that just happen on their own. When we talk about organic brain syndromes, we're talking about syndromes that happen secondary to something else. So if somebody has hypertension and the hypertension is poorly controlled, the person can have what we call hypertensive encephalopathy. That would be an organic brain syndrome. It's different from somebody who develops psychosis that is not linked to any medical illness. There are focal disorders. Those are the cerebrovascular accidents, which most likely, again, the neurologist would have touched about. And then the generalized impairments like dementia and delirium. So let's talk about depression. This is the commonest and the biggest, okay? And a lot of what we'll be talking about here will be hinged on a study carried out by Professor Gureje and his group in Ibadan in 2007. So depression is associated with increasing level of urbanization. When we were more rural, we moved about, our houses were without fences, we knew our neighbors, we were more communal, so there was help. But urbanization has created what we call social isolation. So even the Zoom and the WhatsApp that pretends to want to bring us together cannot do it as well as what we had before now. Low socioeconomic status, also a predictor to depressive illness, low social support, like I said, and poor physical health. One of the major risk factors for depressive illness is poor physical health. So if at the time a person begins to grow older, he has decline in his physical health, say he has visual impairment and now needs somebody to take him about, or he can't bend down, he can't wear socks or remove his socks, he can't even wash his back and all of those things, then you see poor physical health makes a person at higher risk of being depressed. Unfortunately, only about 37% gets treated. So the vast majority of older persons who will suffer from depressive symptoms will not even have access to treatment. Where they do have access to treatment, they would have suffered for about 5 years before somebody will even say, oh, maybe they can even help mama in the hospital. Let's go to the hospital. Otherwise, people tend to diminish those symptoms as part of old age, and then they don't have access to treatment. Poor socioeconomic status and rural dwelling predicted no treatment. So for those who are poor, for those who dwell in rural places, they are not even likely to seek any treatment at all. And depression tends to lead to functional impairment, decreased quality of life, and increased mortality. Increased mortality even from other medical conditions. A depressed person who has hypertension will do worse than somebody who has hypertension but without depression. Still on depression, let us be clear that depression is not caused by old age. It is not invariable that a person will be depressed as they grow older. And the people who have depression fall into two categories. If you look at the life course perspective, there are people who will have depression for the first time later in life. They have never been depressed in their life until this later stage. But there are people who have had depression since age 20-something, 30-something, that because of improved medical care tend to live long. And then they have grown with their depression into old age. So they are not the same category. Some people are developing it for the first time, but some people have lived with it for a long time. The triggers for depression more likely to be found in older persons include bereavement, social isolation, poor health, and caring role. We've talked about the first three. We've talked about bereavement, we've talked about social isolation, we've talked about poor health. Let us talk about caring role. Especially for women, older women tend to take on disproportionately the burden of caregiving compared to men. So that 65-year-old woman, if her husband has a stroke and is admitted in the hospital, is the one that will be made to go and be sleeping on hospital ground. You know that in the hospital, they don't give two beds, one for patient, one for relation. No, we admit the patient, the relation will suffer. Okay, so that's his 5-year-old woman who needs care herself, is in the hospital to be looking after her sick husband. Let us reverse it. If it were the woman who had the stroke, it would probably be the children who come and stay in the hospital rather than the husband who is well. So that caregiving role, then you come to things like Omugo, you come to role reversals. HIV caused a lot of problem. You had lost generations. So you have grandparents taking care of grandchildren whose parents have died from HIV. So at a time when they are not supposed to be taking care of any young child. So that caregiving role is a risk factor for developing depression. Other risk factors, the female gender, living with disabilities, sleep difficulties, which is quite common in older persons. Of course, previous episodes of depression, and we've said it before, low socioeconomic status. Importantly, abuse or neglect. Where older persons are abused, neglected, abandoned to live alone, it portends a risk of depression. And depression has comorbidity with dementia, which is basically, I'm sure we've talked about that, up to 25%. In fact, what we say now is that depression is an independent risk factor for dementia. A depressed person has far higher risk compared to the general population. Depression is also a risk factor for stroke, and vice versa. Stroke is also a risk factor for depression. Parkinson's disease also highly associated with depression. And the last bullet there says older persons are more likely to complete suicide. That is due to, one, their reduced physiological reserve. When an older person starts talking about morbidity, they actually mean it. Oh, all my friends are dead. What am I still doing? If unfortunately they start losing even their own children, if a 90-something-year-old loses a 70-something-year-old child, well, we can't call the person child, his offspring, who is 70-something years old, then you can imagine the kind of sorrow that they have to live with, and they begin to really feel morbid and hope that something will take them away. In that instance, if they do try to harm themselves, they usually do not have the physiological reserve to survive such an assault on their health. So what are the pointers to depression? What do we see that will make us suspect that this older person might be depressed? First is a sad mood. Mama is always feeling sad and unhappy. That should not be dismissed as a normal part of aging. Fatigue, feeling excessively tired all the time, no energy. Morbid thoughts. Oh, when will I die? Oh, let me die. Oh, let me go. Oh, God, if I sleep today, let me not wake up tomorrow. And these are things that we've heard from patients. Greatly diminished interest or pleasure in activities, no longer interested in discussing with people, hanging out, going for parties, family functions, and all that. It could be a pointer to depression. Changes in appetite and weight. Now we have to be careful here. Remember, we have said that already there's a physiological decline that is natural with aging. However, this weight loss will be significant. It will be much more than can be accountable for by normal aging. And of course, the appetite, older people don't eat as much as younger people. But again, when you have somebody who doesn't want to eat at all, we are begging mama to take pap, begging her to take small watermelon, begging, and she's taking very sparingly, it could be a pointer to a depressive mood. How about sleep? One of the earliest pointers to depression will be a change in the quantity and quality of sleep, not just the quantity. So they sleep very few hours, and when they wake up, they don't feel refreshed. They feel like they sleep. In fact, they tell you that they did not sleep at all. And then when they begin to say things like, don't waste resources on me now. Why are you taking me to hospital? Why do you want to buy ticket for me to come to London or Abuja? Use it for your children's school. They're already feeling like they are not worthy. Now, this is somebody who gave her own life for you, sold her land to send you to school, did cooperative, did everything. When it is time for her to enjoy small, she said, don't waste resources on me. Sometimes they can have feelings of undue guilt. You see, we've all seen those stories where a woman goes into the market square, claims that she killed Mr. A, she killed Mrs. B, she's the reason why this one is not pregnant and all that. And in uninformed societies, people will gather, bring stone, bring tire, bring petrol, and they will lynch the person. Yet, this person just has a delusion of guilt that is part of a depressive illness. We will not talk about the dementias, except you want me to, you will guide me. I believe that the neurologist would have done justice to that. We will not talk about dementias. We'll go to paraphrenia or late onset schizophrenia. But before we do that, I think this is where we'll take a break and have our introductions. So this is rehydration break according to the World Cup standard now.
Thank you very much. Thank you for reminding us that we are still having the World Cup. You can stop sharing your screen briefly while we have that. Thank you so much, Dr. Shoyombo. That's been an amazing presentation. And I'll just bring up Dr. Sukomi Anjorin, who will be taking the introductions right.
All right. Thank you so very much, Dr. Olusegun Shoyombo. That was awesome. If you will not mind, maybe just for a few minutes, you can be muted. You can mute so that your dog can enjoy the singing that is doing at the background while the rest of us here. Okay. All right. So I'm going to be doing the introduction very quickly. And again, this we have done since we started this series. We've done it again and again just to to answer the question of what is this for? Why are we here? What is this about? And we decided to put it in the middle just so it would be, some people will join late so they will not miss this part as well. If I just to set the piece for it, is to just anchor everything on Ecclesiastes chapter 9, verse 3 to 4. The preacher who haven't looked at everything in the world, he said, this is an evil that ye have seen under the sun, that one thing happens to all. Everybody has something happening to them. You can't say it doesn't concern me. And one of those things that happen to all is aging. And we are talking about it and other things that we talked about on this group. As I'm going to be talking, just introducing this group to us. One thing happened to her. Say, truly, the hearts of the Son of Man are full of evil. And that's also true. Madness is in the heart while they live. And we see a lot of madness also. And after that, they go to the dead, which is the decisive end for everybody. I mean, we may not die, we may sleep, but whichever way you look at it, a rapture may come. But one way or another, physical death is something that is staring everybody in the face. But then he said this in verse 4, but for him who is joined to all the living, there is hope. And that is essentially what this is about. That in all of these myriads and the uncertainties of life, there is hope for somebody who has a link to all the living. And so life is not meant to be lived alone. This group is an online group opened to people from ages 16 and above, and it's there for healing and building healthy relationships. And it's for also individuals, couples, parents, and families to have experience of wholeness, okay? And by the grace of God, it's also open to people from all tribes, all nation, race, religion, background, straight, bent, whatever your orientation is. However, we are guided by biblical principle. We're not saying you cannot come, but our principles are entrenched in what the Word of God says. And for us to know that this group was founded in 2020 by Dr. Temitope Ayedun, the present child. She's the convener. And since then, we've been having weekly meetings, mostly, primarily actually on Fridays via Zoom and YouTube live streaming. And during these meetings, we look at, we have had series on relationships, parenting, blended families, fertility, and now we're doing aging and the elderly, and it's been awesome. On a good day, we'll meet on Fridays in the week, the alternate Fridays, when we have meet to greet, and then we have meet to pray. When we're not praying, we're discussing individuals in the Bible and taking clues from their lives. And I can tell you, I have been tremendously blessed by perspectives of people, by the way people look at things, and it never ceases to amaze me how things can be seen from God's word. And please, you will see in the chat room, it's been dropped occasionally. If you want to be a part of this group, we have a WhatsApp group where also on a daily basis, there is something going on the WhatsApp. There are topics for each of the days that people will drop and just, get views of other people or just give us materials that will help us in our walk of life. And I would want to say, as I stop this phase, so that we can continue the teaching, that if you have questions, there are going to be questions at the end of this presentation, which Dr. Olusegun will be taking. Please note your questions down. If you want, when we get to that point, we may ask you to mute and ask your questions, or you put the questions in the chat room, they will be attended to. And when all is said and done, when we're at the end, we're going to have a group photograph, and I think that's a good one. So would implore you at that point to please turn on your cameras so that we can see your face and not just the pictures you have there as your profile picture or a senior, but it will be just you. And just give us a little smile and we'll take the picture. Thank you so very much. And that is the introduction. I will eat back to Timitope Prison Child. Thank you.
Thank you very much, Pastor Sukome. That's awesome. And I'll just let our speaker for today continue. Dr. Shoyombo, are you ready for us?
Yes, please.
Yes, you can go ahead. You can continue.
All
Thank
right. Uh-oh. Okay. So, like I said, we skipped the discussion on dementias. I believe that that has been taken. We are talking about what is called paraphrenia or late onset schizophrenia. And this is basically an illness that it's a psychotic illness. It's an illness characterized by unusual beliefs. Usually it sets in around the age of 60. The person will not have had this kind of history before. It is commoner in women. They have vivid paranoid delusions. What are paranoid delusions? When people have feelings of being persecuted, oh, they are talking about me next door, they want to kill me. It's because of me that this color yellow means that this will happen. They just have weird interpretations to what ordinary people, what other people will consider normal. So, and you have them, if you've seen an older person who gets very scared. I had a patient who just believed she was living with her son in Abuja and just wanted to go back because she believed some people were taking over her house in Ikorodu and they were going to sell it to other people and things like that. So it can be that serious. So they have persecutory delusions, they have grandiose delusions. Grandiose delusions are those delusions where people have feelings of elevated self-worth. Oh, I'm the queen. I had an older patient who believed that she was the original queen of England and that Queen Elizabeth turned her into black and banished her into Africa. And this every example I give to you is a real patient. I had a patient who had an erotomania, a delusion of love. Now that I see that I'm talking to believers, I wasn't sure. I wanted to ask. And in fact, I removed some slides because I wasn't sure, because this was an edited slide from a presentation I did in a church. If I had known that I was talking purely to a group of believers, I would have left those slides. I had a
No,
patient.
it's a broad group. It's not
Oh, it's
only
broad. Oh,
believers
I
here.
see.
It's
I
very
see.
broad. There are different
Oh, okay.
religions here.
I had a patient who believed that she was married to what's his name now? Mike Murdoch. I think she believed she was married to Mike Murdoch, and she would go to the embassy in Abuja and say she wants a visa to go and meet her husband. They would ask her who her husband was. She says Mike Murdoch. And then, you know, when you watch these American Christian channels, if you want to support the ministry, text so to 3311 to make your donations. So every money she had was going into supporting the ministry of Mike Murdoch. At some point, her husband, this was a grandmother at the time that we were talking, and at some point, her husband signed divorce papers just so that she would stop paying lawyers. So the divorce was finalized. She never moved out of the house and continued to just say Mike Murdoch was her husband. Olfactory hallucinations will be people hearing things. Okay, now on hallucinations. Before I go to hallucinations, hypochondriacal delusions. So you see older people who just believe that they are unwell. So you see their children going from hospital to hospital, laboratory to laboratory. Mommy complains of leg today, it is neck tomorrow, indigestion. You know, in our environment, they will keep telling you you have malaria or you have ulcer, you have malaria, you have ulcer. So you keep seeing them taking anti-malarials, taking antibiotics, and peptic ulcer medications. Now, these delusions can be with or without hallucinations. What are hallucinations? Hallucinations are perceptions in the absence of a real stimulus. We perceive our environment with our five sense organs: our eyes, our nose, our tongue, our skin, and which one are our ears. Okay, so when people have perception where there is no real stimulus, if five of us are gathered somewhere and Michael Jackson is playing, we will all know that there's this Michael Jackson song playing in the background. But if only one person out of five is hearing Michael Jackson and is not wearing headphones, then there is a problem. So they can have hallucinations, and usually auditory hallucinations. And usually they would hear people talking about them, laughing at them, or making derogatory comments about them. They can also have tactile hallucinations. You see older persons who will say, oh, they feel like there's sand on their hand and they keep washing and washing, but the feeling of the granules of sand on their hand doesn't go away. Visual hallucinations, they can see things that other people don't see. They have olfactory hallucinations, they smell. They have this, and usually it's a terrible smell. Maybe the smell of dead bodies or smell of, it's just of rot or decay or something. I've described the kind of auditory hallucinations that they hear. Personality and intellect are usually preserved. So the one thing about this late onset schizophrenia or paraphrenia is that usually other aspects of their lives will be preserved. Unlike schizophrenia that starts early on that might affect a person's intellect, for this person, they just have those symptoms, but other aspects. So if you dress them up and say, let's go to church, they are fine. Let's go to a party, nobody will know that anything is wrong with them until discussion touches that aspect where they have the unusual beliefs or the unusual experiences. They maintain orientation in time and space, and it occurs in about 0.1 to 4%. It's a wide range, really, so it's not quite common. Okay, it is usually associated with brain changes. So usually if they've had some other health challenge, maybe a stroke or a brain tumor, a neurodegenerative condition, especially Parkinson's disease, those who have Parkinson's disease are at much more increased risk of having these experiences. Social isolation appears to be a risk factor. For an older person to live alone in a house, wake up alone, stay at home alone all day, go to bed alone at night, it's like being in prison, in solitary confinement. Eventually, they begin to have imaginary voices. That's what we would describe it as, but they are actually hallucinatory experiences. These symptoms, interestingly, respond very well to antipsychotics. The life expectancy is not affected by the presence of these symptoms. Another important thing we should talk about is what we call the somatic symptom disorder, which I already described briefly. This is an individual who has medically unexplained physical symptoms. If you go to the doctor and say that your chest is paining you, it is with the hope that the doctor will find a reason why your chest is paining you. If you go to the doctor and say your leg is paining you, you hope that the doctor will find a reason why your leg is paining you. But for these individuals, they have multiple complaints. Usually their tests always remain normal. There is no medical explanation for why they have the experiences that they have. Unfortunately, these symptoms are often dismissed and say, oh, mama is old, back is paining me, it's old age. I have headache, it's old age. I can't lift my hand up, it's old age. Unfortunately, symptoms can be masked by comorbid medication. So because older persons usually have multiple morbidities, the people around them tend to explain away anything they have by existing morbidity. It's still part of the diabetes. Oh, it's still part of the hypertension. Oh, you know, mama had surgery there 30 years ago. That is why she's having this experience. So those things are dismissed. Usually this, like I said, the complaints are excessive for any medical disorder that may be present. What I usually say is avoid endless investigations. Once you've done the basic investigations, if there's no pointer to anything advanced, usually we are dealing with a somatic symptom disorder. We address this by counseling. Oftentimes medications are necessary, and then we do graded exercises to prove to the person that, oh, you just feel this thing, but physically you are not as ill as you think. That might convince them and help them, because if I think, so you have a patient who thinks that she's going to fall down, that her gait is unsteady, but she has not fallen down even on one occasion. So if you don't encourage her to venture out, she's going to be limited because of that belief that she's going to fall and have a fracture. Other conditions of interest: delirium is a medical emergency. It's a state of acute confusion that happens usually secondary to another condition. So acute confusion means the person was fine, the person is suddenly not fine, and the speech can be erratic, they can have hallucinations, they can have delusions, they can be agitated and violent, and then the sensorium changes. Sometimes they are fine, sometimes they are not fine, I would say that is delirium. The intervention is to look for what is causing it and to treat it. Bipolar affective disorder, like depression, people can have bipolar disorder and grow old with their bipolar disorder. The bipolar disorder just describes an illness where people have switch in mood, in extremes of mood, from a depressive mood to a manic mood. Anxiety disorders, very common. Seldom do they get referred because, again, symptoms are dismissed. So I'm sure that I can almost bet that every one of us here has at least one older person, or used to have at least one older person who will not rest the moment you say you are traveling. Oh, Shogun is coming to Lagos from Abuja. Every 10 minutes, a phone call. Have you reached Abaji? Are you in Gwagwalada? Are you now in Owo? Have you reached this? Have you reached Agam? So you have those people who can go to Olympics and win gold medal in anxiety. Of course, we've talked about late onset schizophrenia, sleep disorders. Now, sleep disorders are quite common in older persons, but another thing that is very common is that we have the wrong expectation for sleep. The truth is that we don't sleep as much in older ages as we did when we were younger. So that in itself can be frustrating. How can somebody be retired, have all the time in the world, and that is when they can't sleep more than 4 hours at night, at a time when he actually has the leisure to sleep 10 hours? It can be frustrating. Of course, eating disorders are also a challenge. Now, what can we do as a community to help our older persons? Offer companionship. One of the greatest gifts you can give to an older person now is companionship. People are lonely. Even to younger group, me and you, companionship is now a great gift. When was the last time you went to visit somebody? When was the last time somebody came to visit you? Every knock on the door, every call on the phone now is for a reason. It's either they want money or something. Civil engineering. If you have an older person around you, you might need to re-engineer the house. Something to hold on to in the bathroom, in the sitting room, so that they don't slip and fall. Large prints. You don't go and put one small sign that says open or toilet. No, it has to be large prints, usually with symbols, so that they can recognize what that symbol stands for. Wellness programs like this discussion, organizing a hangout for older persons where they do soft games that they can tolerate and people just spend time with them. Offer support groups for older persons and their caregivers. So we do not only pay attention to older persons, we must also talk about those who give care to them. It's a lot of work and they need a lot of support. If you have an older person around you, a gift, a meal, grocery shopping, giving books for those who like to read and can still read. A potted plant is good. Buying them pets, if they like pets, is also good. We can run errands for them. Okay, let me, on behalf of this older person, go to the market and do some shopping or help them deliver a message to somebody. Transportation. This mama does not go to church. She has arthritis. She doesn't have a car. There's nobody to carry her. If somebody offers to drop by on a Sunday morning, pick her up, take her for service, bring her home after service, she will be very happy. Talk to them. Like I said, when people live alone, they've not had anybody to have a conversation with in a long time, they would appreciate the conversation. In conclusion, mental disorders are frequently underdiagnosed in older persons. They are treatable when recognized. Strong interrelationship between somatic illnesses and mental disorders and social factors. So those social factors that we talked about, retirement, bereavement, okay, social isolation, those things play very important roles in development of mental disorders in older persons. Mental health is important for quality of life. And like was said when I was being introduced, because we are also planning to grow old, what is good for your heart is good for your brain. You and I should prepare for our own old age now by being active physically and mentally. I'll close with this quote that shows the impact of support. Volunteers who reach out to the elderly members of the community, especially those who live alone, and offer them meals, transportation, help with personal errands, or even a little conversation, and making visible the love of the invisible God. Thank you all. That is the presentation. I think we'll go to questions now.
Thank you so much, Dr. Shoyombo. That was an amazing presentation. So it's time for questions. I hope we have loads of questions for him. So if you have a question, please raise your hand. I hope you're able to do so. If you look under the React button, you'll find the place where you can raise your hand. And if you're, for some reason, unable to use that or your background is busy, you can type it in the chats. That was a great presentation. Yes, I think we already have one question. Pastor Sukomi, let's have your question.
Oh, okay. Thank you. All right. I actually have like 3 questions, so I would ask
only
them.
you.
Now, I'm sure Dr. Shoyombo would be expecting that. There's no way you will have this kind of presentation, not only that you have excellently delivered it, it's also something that is common. I mean, is of public health importance. And except you are living in the jungle, you will not have 1 or 2 persons and that you can. So, and just few questions. Some of them may really not be, maybe not for just personal knowing, and just for general knowing, so that they also dilate a little bit on them. So, knowing that, I just wanted to I know it's not only depression you talked about, but these questions are actually more about depression, knowing that it's also a silent thing that most people cannot recognize. So how, in your practice and from your experience, how do you help us to make the difference between the typical sadness and when a person is crossing to depression? How do we make a difference between those? And the second question would be still about depression. For most part, I know there are medications that are used, and because of the stigma, apart from people even getting diagnosed, for some people, because of the stigma of it, because they will call it something else, you are mad, you're crazy, or something is wrong with you. And then also even believers, especially for some of us who are Christians, the labeling of it that I'm depressed. Don't you have God? So don't you believe in God? I mean, pastors. So people will not want to come out. But apart from medications, are there other ways by which people can handle, especially depression and things, to help to mitigate against the effects of it? And lastly, and you talked at the end about it, but you spoke generally on how to support people who are going through some of these psychiatric conditions, but particularly zeroing in on depression. What are the things that you would want to advise that if somebody has been either diagnosed or observed to be having some of these symptoms, how can we help our loved ones who are struggling with this? Those are my questions.
Thank you very much, Pastor Sukomi. How do we differentiate between depression and normal sadness? Thank you for that question. We all get sad from time to time. We don't have money. Your football team loses a match. Somebody jilts you. We all get sad from time to time. The difference is that in depression, the sadness is pervasive. It lasts long. Usually we'll say for a minimum of 2 weeks. The other thing is that for a depressed mood, even when things happen that should make a person happy, that mood is not reactive. So yes, the person is depressed, but in the period that person has been feeling sad, say somebody has given birth and everybody is joyous, but that person can't find themselves to share in that joy. In fact, people will start thinking that, is this person a witch? Why is she not expressing joy and happiness over this good news. Now, depression is more than just sadness. The associated loss of interest in pleasurable activities and the associated fatigue, all of them prolonged, will differentiate it from regular sadness. Somebody can be sad, he still wakes up in the morning, takes his bath, dresses up, still will cook food, wash plates, do things that they used to enjoy. In fact, the person who is sad can say, oh, because I'm sad today, I want to go and buy chocolate. Chocolate makes me happy. That's different from what a depressed person would do. So these are the ways that we can tell oftentimes the difference between depression and regular sadness. Stigma, medications, other treatment modalities. Stigma is one of the biggest barriers to people seeking treatment, because depressive illness can make someone seem like an ungrateful person. Somebody can be depressed in spite of the fantastic things God has done for that person. And it's not because the person is ungrateful. Wonderful marriage, lovely children, perfect career, good physical health, yet the person is depressed. In fact, when ordinary people come and counsel the person, what they will say is, see what God has done for you now. Can't you just be grateful? It is not about lack of gratitude. It is an illness. There's actually a chemical basis for it. There is low levels of serotonin. That's why the person feels depressed. And that's the basis for the use of medications. But it's not medications alone. There's psychotherapy, because in depression, people can have what we call cognitive distortions that we need to address psychologically. For example, a person who is depressed can minimize positive events. I passed this exam. The examiner just wanted to pass everybody. Instead of him to take credit that he passed exam, so this man just passed me. But when he fails exam, see, I'm useless. The exam that everybody is passing, I cannot pass. So it will magnify negative events, it will minimize positive events. These are things that need psychotherapeutic intervention. There are yet other interventions. Exercise is an invaluable medicine for treating the mood. However, remember that depression already is an illness that makes somebody feel tired. How do you tell a tired person to go and exercise? So when we're talking about mild and moderate depression, we can often tell people psychotherapy, exercise, those kind of things can help. But in severe depression, usually you would have to do medications first before the person gets better. Forgive me, the last question was on
How to support someone with depression.
how to support someone with depression. And those are the things we listed. How to support a regular older person is how we support a depressed person also. Just be there for them. Assist them with what we can. This is not peculiar to older persons. So somebody has given birth to a child. She has postpartum depression. She cannot even bath that child. She cannot even bath herself, cook food. When we come, can we sweep her floor, mop, wash clothes, bring food? Just take care of basic things that would have suffered, that the things that person would normally have been able to take care of. Above all, can we encourage that person to see a doctor? Sometimes we might have to escort the person. Don't worry, I'll drive you to the hospital. Women are wonderful people. When they are sick, they are still thinking of other people. A depressed woman will not go to hospital if she's not sure who she's going to leave the young children at home with. So going there and saying, you know what, I'll babysit these two children, you go see the doctor and take care of yourself, would be a great way to help a depressed person. What is unhelpful is to say, put it out of your mind, or it's just in your head. Oh, come on, snap out of it. No, that is very, very unhelpful. So I hope I've answered those three questions, Pastor Sokomi.
Thank you so much for those great answers. And yes, mental health is really common. And some of us have actually had issues with mental health and have come out of it. So I think we should talk about it a lot more. I think the other thing is that I know you didn't mention this in particular, but you've mentioned it in a way about helping people who have depression. And don't say, call me if you need help. because telling them, call me if you need help, is giving them another job to do.
Another job.
To start thinking about calling you. Just offer help. Just be there. And if we think of the biblical example of Job, when calamity happened to him, and I'm sure he was definitely depressed, we see that the one thing his friends did not do at the beginning was even talk. They were just there, sitting with him without saying anything for almost a week, which I thought was out of this world. How will you just sit with someone and not even talk? But I guess just their presence.
The presence can be reassuring.
And reassuring, you know. So food, helping to clean. Don't give them another chore to do. Just help once you can think of it. If you think it will be useful, then just offer it. So that was what I wanted to add to that. I'll let Auntie Adesua ask her question now.
Yeah, thank you very much. It's on depression. It's not quite a question. It's more of an explanation. I went through depression from secondary school, but I came out of it COVID-19. I did not go through medication. I was given medication. I was diagnosed. This is not a question of, oh, she feels sad. No, it went on for, I'm talking about secondary school. I'm going to be 70 this year. So I came out COVID-19. But the thing with mine is like, when I got the medication, I asked the pharmacy, can you explain these medications, what they do, whatever? He says, wow, these are strong medication. They'll make a zombie of you. That's all I remember. So I refused. I put them in the drawer. I threw them away 2 years later. And I just said to myself, I talked to God. I know it's not something that'll be easy for a lot of people to do. But another thing is I had family support. My brother in America sent me a book. I too was studying, finding out about it. My sister was helping me. I had a lot of family support. And the period I had a child, I kind of came out, I said maybe 3 years or so, you would say, I didn't really go through depression because maybe there was something, you know, but I had to pretend. In fact, today, my son cannot be fine. If you tell him that your mother, he will almost get very angry, you know, he just can't accept it, you know. What I did was pretend. Yes, I will muzzle up all the energy I have just to get him ready for school. The minute he goes to school, boom, I'm to bed, cover myself up, shut myself out, you know. When it's time to come back, oh, it's coming back. Okay, another 5 minutes. 1:45, I'm able to get the food ready. Just once they come, oh, how are you? How was school? Once the lesson teacher comes, I escape. So I did that for that period. That's why he will not believe it, you know. Somehow, and God gave me the grace. And another thing I did was I knew I had to eat to be healthy. And so I study about eating. I think all these things are things that helped me because I lived alone. Of course, after my son went to school, I was living alone. Because what used to go through my mind, oh, it's like, life is this, just wait, your son will help you when he gets a good job, he'll manage, you don't have to. I was feeding on that and was saying, okay, yes, you know. And throughout that period of depression, all those years, I did not keep a job for 1 year. 6 months, 4 months, but I was always getting good jobs because when I'm out of depression, I'm a go-getter. My head is correct, you know, I can function. Then I'm on the fast lane. It's like I want to make up for that time, not consciously, subconsciously.
Seems that network is cutting out.
You know, but you have to know how you can manage. Sorry?
Okay, your network seems to be cutting out. I'm hearing you now, yes.
I'm sorry, yeah. Okay. So depressed people are usually quite intelligent people. I think one of the reasons is because they're intelligent, they feel they can achieve more and they have not been able to. So that's one of the things that gets them depressed and they feel though they have not met the mark. It's like they want the best, you know, and once they don't get it, you know, they get depressed. So the all symptoms the doctor talked about, avoid people. If you come visit me, it's bad. Oh, you put that such a that's there. The thing is having confidence in yourself, having something to do, and when those thoughts come, tell yourself positive things. You know, counteract it. That's the word. Counteract it with positive things.
Thank you so much, Ma. Sorry, your network seems to be cutting out, but I think we've gotten a bit from what you've said, and I'll just let Dr. Shoyombo speak to what you've already said. Thank you, Ma.
Well, I think the first thing is to thank Madam Adeswa for sharing her personal story. I always tell people theory is different from lived experience. Now, if you are peri-70 and you've been depressed from secondary school era, I will accept it from you that the drugs that were used 50 years ago, 60 years ago to treat depression are not exactly the same kind of drugs that we use today. Having said that, I will take the fault on behalf of the doctors to say that we should have explained to you more about the drug. It is not quite easy for somebody who did not interact with the patient to sound so dismissive. The pharmacist did not hear the story, does not know the suffering. He just picks up a drug and say, these are strong medications, I didn't use it. Now, I'm happy for you that it seemed that you might not have been on the severe spectrum of the illness, and that's why you remained functional. And I did say that in the course of my presentation about how women can manage to remain functional despite being depressed, because they feel like there's a bigger responsibility and they just manage to fulfill those duties. Depression also, like other mental illnesses, has a natural history where with or without treatment, it waxes and wanes. So there are periods when it will let up and you'll be able to achieve things. But the truth is that you most likely probably would have done better with treatment than without treatment. And then to address the issue of medications, every doctor that treats a patient wants the patient to get better. We are not interested in making anybody a zombie. Severe depression that causes severe depressive stupor, what we call catatonia, actually makes the person a zombie, much more than any medication will make somebody a zombie. So doctors, prescriptions are done responsibly. We make those adjustments where necessary just to make sure the person is functional. In those days, once you start taking a medication for a psychiatric illness, everybody knows you are taking it because you have a certain, you are drooling saliva, you are stiff, you are doing all that. But there are very many people now taking medications that nobody can even have an inkling that they are taking medication. So maybe development has come. We have newer medications with better side effect profile, and people should not be afraid of the treatment more than they are afraid of the ailment itself. That would be my response.
Thank you very much for that. I work as a GP in the UK, and I do see quite a number of patients with depression, although most of them are younger patients. Not very many of them are older patients, or if they are older, maybe they've had it for a long time. And when we give them medication, we have to tell them that sometimes it might not work for you, but we have many other options that we can try. Or if you have any side effects, come back, we'll change it. And so they know that they can come back if they do not tolerate it or they have side effects that they feel are bothersome. For instance, there was a patient that came and said she's yawning all the time. And one of the side effects of that medication is yawning. And because she's a professional, it was embarrassing her everywhere she went because she was yawning. And so it was changed. So there are different options that can be tried. And also, some people want to know whether it's addictive. Some people want to know whether they can come off it. Many times, if it's a life circumstance that causes it, like bereavement or sadness or something like that, or some grief in some way, many times after a while, they can come off the medication, wean off slowly, and they can stop it. So it's not something that needs to be a permanent medication, but needs to be evaluated from time to time. And some patients just come and just say, doctor, do you think I'm going to get well? And I say yes, because that's one of the things that most people that are going through a mental illness need to hear. They need to be given hope. And whether that hope is from their health professional, is from their family, from their friends, that's a very important thing that everybody needs. And that is hope that things are going to get better. I'll let my auntie, my big auntie, ask a question now. Mommy Bafunke, let's hear your question, Mom.
Good evening.
Good evening, Mom.
My question is, there are two in one. Number one, can somebody with depression recognize that he or she has depression? Number two is that can somebody else, looking at the actions of a particular person, like somebody who is always erratic, shouting, and every small thing getting angry, can that be termed depression?
Thank you, Ma, for this two-in-one question, and I love these two questions. Can somebody themselves know if they are depressed? For a first episode, the person may not know. Something that you haven't experienced before, you will not know what it is that you are dealing with. It's also like somebody who is pregnant for the first time compared to somebody who is having a fifth child. They are not the same thing. However, when people have lived with the illness, interacted with medical professionals, they tend to recognize their symptoms by themselves, such that when they begin to feel a certain way, they will then come out and say, oh, doctor, it looks like this is happening. Oh, I'm experiencing this. I wasn't experiencing it before. Oh, or the last time I had this experience was 15 years ago and it is coming back now. So in that sense, it is possible for somebody to recognize their own depressive symptoms. And that is why medical practice now is no longer just a matter of you come and ask you questions and I give you medications. I would have explained the symptoms and the reason why I arrived at that diagnosis to the patient, such that because Dr. Edu mentioned already that sometimes patients are taking off medications. One of the things when you take patients off medications is to let them know when it seems as if the problem is coming back, so that they come back to the hospital for intervention before it becomes severe. The second question, somebody gets angry, erratic. Could that be depression? Many people who are lay people will call doctors and say they think somebody is having depression. That diagnosis should only be made by a diagnosis. What a lay person can recognize is an unusual behavior. This person used to be like this, he has now changed to this. The person who is not medically trained need not bother with whether it is depression or another illness. The doctors will take a decision as to what the diagnosis should be. Can depression make somebody angry and irritable? Absolutely, yes. One of the symptoms of depression could be an irritable mood or somebody getting angry. In fact, men tend to mask their depression in anger. Some depressed men come back from work, everything is catching fire. Children are hiding, wife is in the kitchen. Everybody just doesn't want to come in contact with that person because it's going to unleash anger on everybody. But if you look deeply, that person is suffering from a very bad mood. But depression is not the only illness that can make a person angry. Bipolar can make a person display such anger. Schizophrenia can make a person display such anger. Alcohol dependence can make a person display anger. So it is not enough to pick one symptom and then find a diagnosis for the patient. So in summary, diagnosis should be left for the medical professionals. You just recognize symptoms that you find unusual and uncomfortable and encourage the person to seek help.
Thank you so much for that. Thank you.
Sorry, can I just how do you convince somebody with that kind of a episode to look for a medical to seek help?
Yes, ma'am. So it's a very sensitive matter. It's not easy to tell somebody go and see a psychiatrist the way you can tell somebody go and see a cardiologist. You might be met with very stiff resistance. It depends first on your relationship with the person, and there are subtle ways. For example, if we are talking about spouses, we could say, oh, we are having challenges, we are fighting often. Can we go for counseling? Can we go for counseling is different from you need to see a psychiatrist. In Yoruba, they say, olako, olabo. You know, when you say you need to see a psychiatrist, it's as if you have insulted the person. But can we go for counseling? Can we go and talk to a doctor and see how they can help us? Might be a more acceptable approach to that person. So there is no direct answer to this question, but I have a lot of comfort that Dr. Luanuga's hand is up. I'm sure it's an answer, not a question.
Thank you very much for responding to that. I'll take Mr. K. Faj's question, Mr. Fajimi's question, and then we'll go to Dr. Luanuga.
Hello, everyone. My name is K. Faj, Kayode Fajimi. Dr. Olusegun, I want to find out if medication can cure depression. That's number one. Number two, in aging, how can we manage or protect ourselves from being depressed? Thank you.
So in medicine, thank you, sir, Mr. Kefaj. Cure is a very high, shall I call it high standard, hard to reach target in medicine. For example, if somebody has appendicitis, which is an inflammation of the appendix, they go to the hospital, they do operation, they remove that appendix has been cured. If you have malaria, I give you an anti-malaria, the malaria goes, that malaria has been cured until you have another bout of malaria. It is different from chronic conditions that tend to stay. So if somebody has hypertension and you give antihypertensive, the blood pressure becomes normal. But do you say you have cured the hypertension? Usually we will not say we have cured the hypertension. So for depression also, I'll be careful to use the word cure. I have said repeatedly that depression is a treatable illness. We can treat it. Not everybody who has depression has to be on antidepressants for a lifetime. Most of them will take it for a period and they can get off it. Some people, unfortunately, will have to be on treatment for a prolonged period. But like I say, that shouldn't be a problem. When we wear our glasses, we don't go and ask our doctors when we stop wearing glasses. What is more important is to have good quality of life. Some of the people who are dead today, if we can wake them up and give them the chance that you will live long, but you have to take this medicine, they will not argue. It is those of us who are alive that are arguing about whether we should take medicine, whether we should not take medicine. What can we do to prevent depression in old age? Some of them we discussed during the presentation. Number one, good physical health. Exercise, eat healthy, get enough sleep, and all that. Number two, and I'm happy that it is a man that has this question because I always say it when I have the opportunity to speak to men. Prepare for your own future. One of the best preparations you and I can do for our future is to treat our spouses well so that they don't deal with us in old age, abandon us and go and do omugo somewhere. Take care of our finances. Take care of our children. build good social support. Some of these things I say with a lot of humor, they are actually true because they are things that have come from patient interaction. So you see men, they retired as director, PAMSEC, but at the time of retirement, everybody has disappeared. You can't abandon a woman for 30 years pursuing career and expect that she's sitting down waiting with open arms to receive you in retirement. Even if she has not divorced or moved away, she has emotionally checked out. The children that you did not attend their open day and inter-house sport and prize giving day, you suddenly think that they will be there doing daddy when we retire. No, they will not be there. So in summary, again, take care of your physical health, build your own social support, friends, family, religious gatherings, so that you have people around you and you don't do old age alone. Again, I'm sure that now this is not medical information. There are many people here who can give advice on the things that we can do to make our old age better. Even me, I'm waiting for answers, Mr. Kefaj. So we are waiting together.
Thank you, sir. Mhm.
Thank you very much for those great answers, and I absolutely love your humor. I'll take this question from Pastor Ruben, and then we'll take a comment from my big auntie, Dr. Luanuga, and then we'll come back for your closing remarks. No, we'll take Pastor Ruben's question. I don't know if there's a question or comment. Pastor Ruben, can we have your question? Your hand is raised.
I was hoping you could see my video, but I can't somehow get
It's
my
okay.
video going. Yeah. But
It's all right.
thank you very much for a very productive and informative session. Working as a pastor, I see this weekly, and sometimes we don't have the skills to reach out. You see someone suffering, and sometimes we are passive. We don't know how we can really navigate. We've had some mental health awareness sessions as of a year or so ago, but my immediate concern is in the midst of trying to encourage members to look after their mental health. When does it become necessary? Because obviously you might see someone who becomes a danger to others, and you're thinking, well, what's my responsibility, or what are our responsibility as leaders, when clearly you can see there's the mental health issue, and in the background you are gathering that they're not taking their medication. So when does it become necessary, or how do we intervene in such cases? Is my question, Lee. Thank you.
Thank you, Pastor Ruben. I'm sure Dr. Ayedun too will help me here, because
Yes.
the code of ethics for pastors might be different from the code of ethics for doctors. For us, if we think somebody is a danger to other people, we have a duty to warn. Okay, whilst pastoring is very similar to being a doctor in terms of having confidential information, I do not know if there is a central regulatory body where the pastoring license will be withdrawn because somebody called somebody's mother to say, look, he's not taking his medicine, or indeed, if the person is a clear danger to other people, you issue a warning. I think that it is possible that you might even be in bigger trouble for not issuing that warning. And let's even remove external trouble. How about a person's conscience? If I know that somebody is in trouble and I do not do anything about it, and then something terrible happens, how do I live with that? Again, this is not particularly a medical question, so I'm happy for anybody to chip in.
Okay. Because I also know Pastor Ruben is in my part of the world, I think just even though there's no particular code that will say that if you don't intervene, there's going to be a problem with you. But on the basis of conscience, the basis of relationship, the basis of possible harm, it will be in the best interest to possibly alert either the ambulance services or the police if you believe there's a threat of immediate harm. Because you don't want a situation where, for instance, the person hurts themselves, like harms themselves, commits suicide, or hurts a child, or hurts another person, or is at risk on the road to other passengers. So in that case, you would want to place a call and let them know that you are very worried about that particular person, and let them take it from there. So they are then likely to go and do a house call, reevaluate the person, or find the person where they are. So that would be the answer from my end. Pastor Sukomi will just take your comment or question briefly. Yeah.
Yeah, thank you. While I'm not a psychiatrist or anything, like Dr. Olusegun said, this seems to be a bit general. I live in Illinois, United States of America, and the law here for a person, and I'm also a pastor, so double as both. The law here is that you are while you are a mandated reporter for child abuse. If you notice any child abuse going on, you are mandated, it's a mandatory responsibility for you to warn the public, to report. But when it comes to mental health issues, health professionals are the ones who have that responsibility. As a pastor, I can't go and report and say somebody has a mental issue or they are having depression, please. But if somebody comes to me and tells me, so person, I'm going to shoot them, I'm going to kill them, or I'll go to so place and go and shoot up the place, I also have I have the right to go and report that kind of thing. But that somebody is having mental issue and depression, but again, there are no clear demarcations, but just to say what is obtainable on this side of the world.
Thank you very much for that addition. Of course, it would depend on the severity, the apparent or real risk involved. I'll take my big auntie's comments now, Dr. Shola Oluwanuga. And thank you very much, Ma, for the connection. She's the one that connected me to Dr. Shoyombo. Thank you, Ma. Can we have your comments now?
Thank you. I was trying to unmute myself. Thank you very much, Praising Child, as usual, for putting this together. And a great thank you to Dr. Shoyombo. Dr. Shoyombo has been an amazing person ever since I knew him, and that's about 15 years ago now. I don't know whether when he was introduced, they told you he was an award-winning psychiatrist because he won the gold medal in his set from the National Postgraduate Medical College in Psychiatry. So we're very, very blessed to have him here. Apart from his taking a master's in gerontology from the University of Southampton. So when I was asked, I said, I know the very person to give this talk. And listening to him, of course, as I've listened to him many times, I'm not disappointed. Thank you again, Dr. Shoyombo. I just wanted to, I know that you didn't have all the time, Dr. Shoyombo, and you might have left some things out, hoping maybe people would ask questions about them. So I am going to make you talk about those things by asking you. I would like you to briefly talk about dysthymia, which people may not easily recognize as much as depression. And I also would like you to talk about taking the elderly people to old people's home when they have severe mental health issues in old age. Thank you.
Thank you very much, ma'am.
I think you were expecting her to give answers.
Thank you for your kind words. I said I was looking for answers.
No, she's giving you more questions.
Thank you very much, ma'am. So when we talk about dysthymia, the way I like
Sorry, Dr. Shoyombo, let me just add seasonal affective disorder to that one.
Seasonal affective,
to your list. Yes, thank you.
Okay. So I like to describe dysthymia by saying, if you did geography, and I'm sure even all of us did a bit of it, and you look at the globe, the middle of the globe is the equator, isn't it? And then the top part is called the North Pole. and the south part is called the South Pole. So when I want to describe bipolar disorder, I tell people that that's where the name came from. Where the equator is the normal mood, mania is the North Pole, and depression is the South Pole. So if you're talking about dysthymia, some people feel sad, but their sadness doesn't quite hit the South Pole. Yet, it is not at the equator. So it hovers somewhere between the equator and the South Pole. So they are sad, but they are not so down and out. So they remain functional, but they remain functional with some difficulty. So it's sadness that has been pervasive. When we're describing depression, we say for at least 2 weeks. For dysthymia, this sadness would have been there for about 2 years. You see, for many people, nobody asks them the question, are you happy? You ask some patients that question, they first take a sigh and they tell you, no, they can't remember the last time they actually felt happy. But when Madam Adeswa was telling us her lived experience and personal story, she mentioned the word pretend. So these people pretend, they manage, it's not pretend in a negative way, they manage to show up when it is most important, just to keep up an appearance. It's just like somebody saying, oh, everybody say cheese, and we say cheese. Cheese doesn't mean we are happy because we are showing our teeth. And that's what dysthymia is. So it's prolonged sadness that is not quite as deep, but nevertheless quite debilitating because it affects a person's quality of life. Seasonal affective disorder would happen more in the temperate regions because of change in the climate scenario. You know, it's an illness where people, so where you have long nights, people in darkness for extensive periods, the weather is very cold, they can't go out, limited connections and things like that. So you have depression that tends to come at those periods, and then it lifts in the summer where the sun is out and activities are there, and we'll say it's seasonal affective disorder. Now, that's not the only type of depression that is associated with different conditions. Women, for example, there are women who have what we call the premenstrual dysphoria. They have mood changes around their menstrual period. Okay, you have those, like we mentioned earlier, who have postpartum depression, depression that happens in relation to pregnancy and childbirth. So I'm happy that you added the seasonal affective disorder so that we can point out that there are depressive illnesses associated with different conditions, and one of them is seasonal affective disorder, where part of the treatment will be to say, look, go and get some sunlight. And you see, typically also people who may not even be medical have some associates. There are people who escape the winter. Once the winter is coming, they travel, if they have the means, to a place where they will not be faced with that type of weather. So they are kind of envisaging that this weather is not good for me. Let me go to a place that is better. That would be my response. I hope it's a pass mark. You know, some questions are exam questions.
Thank you very much.
Taking people to care homes.
Yes, yes.
Very interesting. We used to say that it was something that wicked people did. Your parents took care of you, now you cannot take care of your parents, you are putting them in care homes. And researches have been done. The attitude of Nigerians, especially who live in Nigeria, is shifting. The reality is that when a person grows to a certain age and cannot live independently, they will need somebody to look after them. So for people who go to care homes, because you've had the issue of elder abuse, what's the option to not going to a care home? My mother stays at home, I get somebody to look after her in the house, but I'm not there. So some people prefer to deal with an institution. So they believe that the institution would maintain standards. It's like putting your children in school. You can hire somebody to come and homeschool your children, or you can take your child to a school where you believe that the school will maintain certain standards. They will make sure that, oh, the teacher is of this quality, these are the do's and the don't, so that the attitude is no longer that of abandonment. And that is where we should draw the line. People should not put their older relations in care homes and abandon them, where you now visit once in 2 years, once in 6 months, just make a phone call every few months and things like that. It's not a place for abandonment. It's a place where there should be professional service. The people who are taking care of them are trained to provide such care. But like we say, as much as possible, people should live at home where the resources are available, where the social support is available. People should be at home.
Thank you very much. Last question, which I don't know how you're going to answer it, is the issue of social isolation, which you've mentioned more than once about being a risk factor for mental illness. Most people, as they get older, don't make more friends. And so their circle gets smaller and smaller. How do you think the older and aging adults can cope with social isolation?
So
If they are
far,
if especially if they are in this category that they say, I don't make friends easily. You don't know what's in the heart of anybody, in the heart of any man. And they've gotten a bit more suspicious as they got older.
so far, all of us that have spoken are Black people, maybe Nigerians, you know.
Except Pastor
Yeah,
Ruben.
yes, and that's why I said, oh, so you see that we are just beginning to evolve from the practice of having family always around us. So these concepts are relatively new to us. We didn't grow, I mean, you grew up where there were uncles and aunties and first cousin, second cousin, fourth cousin, and people that they say you are their relation and you don't know. There's no English word for the relationship you have with them. They are not your cousin, they are not your nephew, but they say you are relations and things like that. But now we're in a situation where we are growing into these ages without this kind of social connections. We're also in ages where we work in places where we'll probably not retire. Or even if we retire there, some of the colleagues that we work with will not retire there. Some people buy their first home in old age, maybe just before retirement. So they are living in a neighborhood that they had never lived before. So it's not quite easy to form new relationships at those periods. In the past, you go to a church where they know your grandfather, know your father, they know you, they know your entire lineage in the church. But once you relocate to a new place, you are forming new connections altogether. So not to overburden the problem, what is the solution? We just have to be deliberate in forming new relationships. So look at social events around you that are friendly, and especially for believers, Bible study groups, breakfast meetings, sports clubs, whatever you can do. If it is golf or it is table tennis or if it is Ludo and Dayo you want to play, but just gather with people from time to time, visit people, people will visit you. What you want, you should also give to other people. We should live in the reality that we are not likely to be able to pin our children down. We can hold on to them until they are 18, 20, 25. Once they fly, they can decide to go to Australia, Uganda, China. You need new relationships.
Thank you. Thank you so much. Let's give a round of applause to Dr. Shoyombo. It's been an awesome session. Thank you. Thank you. Thank you so much. Okay, so big thank you to everyone, amazing listeners on YouTube and on the Zoom today. Thank you for your questions and your contributions. It's been awesome having you all here. Our next session is going to be on urogenital concerns in aging men, which is going to be a very interesting topic. And it's going to be taken by a professor of urology. I think he's actually here today, actually. I think I saw him a minute ago. Yes, Professor Misojo, he's actually in the house. Yes, so he's going to be taking that session. And it's one to look forward to. You're going to come and ask all your questions. It's going to be quite broad and it's going to be exciting. So sit tight for that one and invite your loved ones, men and women. So it's for men and the women that love them and their children too. It's going to be very insightful. Big thank you again to our speaker. We are absolutely delighted to have you with us. And thank you, Dr. Oluwanuga, for making the link. Mommy Adesua, you have a question or a comment?
Quick one.
Yes.
No, a quick comment. I had written something on the chat. I said I will not advocate that people should not take medication, please.
Yes.
My own case was just once off.
Yes.
And you know, I think spiritually, and then the kind of person I am and the support I had made a world of difference.
Yes.
You know, because all the things the doctor talked about were on point. You know, I went through all that. I felt all those things. Thank you.
Yes, ma. Thank you for that clarification. Thank you, ma. Okay, so we'll just have our group photograph now. Dr. IJ, are you ready for us?
Oh, okay. Okay, I thought you said Angie. Okay, Dr. IJ.
No.
I wanted to say, have I become the photographer at last? I was just standing in.
I know. You don't want to become our professional Olia. Dr. IJ, are you there? Let us know when you're ready. I can't hear her voice, so I'll let Dr. Anjorin do it again today.
All right, but I see her. Okay, maybe she's busy. Okay,
I don't know.
All right, let's just do it quickly.
So please show your photograph. Give us a beautiful smile. If you're here, reach out to me. I'll send you the photo if you're not on the group. Otherwise, it will come and go on the group.
I am smiling already. Everybody, I see some of us not turning on our cameras. Maybe
take cheese, pretend.
We can. All right, let's go. Let's do it.
Camera is not coming on.
Oh, okay. All right. Hold on.
Have you succeeded? Okay, no. All right. Okay, just take it.
Done.
Awesome. Thank you very much. Sorry. Okay, so let's take our motto. You can repeat after me. I live in love.
I live in love.
I stay in peace.
I stay in peace.
I shine my light.
I shine my light.
I use my power.
I use my power.
So help me God.
So
help
God.
Thank you so much, everybody. See us next week.
Thank you very much.
Bye.
Bye.
Thank you.
Thank you, doctor.
Thank you.
Thank you, everybody. Bye-bye.
Thank you.
Bye.
Thank you.
Bye.
Thank you,
Bye.
Thank you, Dr. Shoyombo. Thank you. That was amazing. Thank you, Uncle Kayode Anwo. Thank you, Prof. Misojo. Thank you, Dr.
Thank you.
Kodu. Thank you, Sister Nike. Thank you, Dr. Anjorin. Thank you, Mommy Adesua. Thank you, Dr. Luanuga. Thank you, Prof.
Thank you very much.
Mommy Ayedu. Thank you, Pastor Ruben. Lovely to see you. Thank you, Mommy Jaji. Thank you, Mr. Kpaj. Thank you, Grandma Shoromo.
Thank you.
Good to see you.
Thank you.
From Canada. Thank you, Dr. Akitunde. Lovely to see you. Thank you, Uncle Tunji. Good to see you. Thank you, Mrs. Odemuyiwa. Thank you, Mrs. Daramola. Thank you so much. Who have I missed out? Thank you, Mommy Bafunke. Thank you, Mrs. Taiwo. Thank you, Sister Toyin. Thank you, Sister Eniton. Thank you, Dr. IJ. Lovely to see you. Thank you so much.
Have you said thank you to Mommy Ayedu?
Yes, ma. I joined her with Prof. Ayedu. Thank you, Techno Spark. Thank you, Dr. Adejumobi. Thank you, everybody. See you next week. Please invite people. It's been an awesome time here.